we have chronic cutaneous lupus erythematosus. Chronic cutaneous lupus erythematosus is called CCLE. So we have ACLE, we have ACLE, and we have CCLE. So when you talk about ACLE, the most common pattern of ACLE is this one. This is called as a mala rash. Okay, this is extremely photosensitive rash. That is the first point. It is the most common rash. It is an erythematous rash. So highly erythematous, most common photosensitive rash. So erythematous photosensitive rash is a mala rash. It is the most common type of rash, which has a tendency for scaling, plus or minus scaling, but it is a non-scarring rash. So it is a non-scarring rash, may be associated with non-scarring alopecia and also associated with oral ulcers. Typically, you see ulcers on the hard palate. So hard palate ulcers, non-scarring alopecia, non-scarring ulcer, non-scarring rash, scaling plus or minus photosensitive, and it generally tends to spare the nasolabial fold. That's how you know, because dermatomyositis rash tends to involve the nasolabial fold. This tends to spare the nasolabial fold. This is called as a mala rash, and mala rash is not a premalignant rash. It is a non-premalignant rash. Okay, so this is what we call as ACLE, or what we call localized ACLE, which is called mala rash or butterfly rash. But ACLE can be sometimes a generalized ACLE like this, or sometimes can be a toxic epidermal necrolysis like this, but that is not common to see. What we commonly see is the localized ACLE, and localized ACLE is what we call mala rash. Okay, from ACLE we move to CCLE, then we'll come to your SCLE. So this is CCLE. CCLE you can see is a much more disfiguring rash, and you can see here it's actually very, very bad. Inside CCLE, the most common one we study is a discoid rash. So inside CCLE, the most common one we study is a discoid rash. Discoid rash, point number 1 is this 520 rule, which means 5% of patients with discoid rash have SLE. Okay, whereas 20% patients with SLE have discoid rash. So 5% patients with SLE have discoid rash have SLE, 20% patients with SLE have discoid rash. Discoid rash is seen on the face, scalp, neck. This is where you see discoid rash. Discoid rash is a much more deep rash, no? Which are circular erythematous rashes, where you have this dermal atrophy. Okay, dermal atrophy is there, and follicular plugging is there. So follicular plugging and dermal atrophy are classically seen. They are circular raised erythematous patch, which have hyperpigmentation in the center and hypopigmentation in the periphery. That's unrequired. Then comes a very, very important point that there is pre-malignant risk for squamous cell carcinoma of the skin. Very, very important question. That's a biopsy is required. Next very important question is it is associated with scarring alopecia. In SLE, everywhere we are having non-scarring alopecia. Here you are having scarring alopecia. And there is also one more sign called Carpet-Track sign. Okay, you can see the lesions on the back to see Carpet-Track sign. So Carpet-Track sign, scarring alopecia, squamous cell cancer, circular erythematous lesions, face, scalp, neck, and this is what it is. You can see this is a typical discoid rash. This is also a discoid rash. Apart from these two, so when you look at chronic cutaneous lupus erythematosus, chilblain, lupus profundus, paniculatis, all that is there, but that is not important for us. What we need to study is discoid rash. Okay. Third of the lupus-specific skin lesions is this one, which is called as your SCLE, subacute cutaneous lupus erythematosus. This can be associated with the annular pattern or psoriatiform pattern. Commonly, what we see is the annular pattern. Right? Okay. See what are the points about SCLE that you need to know. SCLE point number 1 that you need to know is that it's a lupus-specific rash, which is a highly photosensitive rash. So like your mala rash, this is very, very photosensitive, and like your mala rash, this is non-scarring. Okay, very important exam question. This is non-scarring. Second point is its association with anti-ROLA antibodies. Very, very important. And its association with HLA-DR3. So anti-ROLA antibodies means it has decreased risk for nephritis and vasculitis. Decreased risk for nephritis and vasculitis. And its propensity to spare the midfacial region. It actually spares the midfacial region somehow. It involves the other parts, the trunk, the forearm, etc., but it spares the midfacial region. Decreased nephritis, vasculitis, anti-ROLA positivity, HLA-DR3, highly photosensitive, non-scarring rash. These are the points. So every single point on these skin manifestations, lupus-specific skin manifestations, ACLE, SCLE, CCLE are asked for exam. Okay, so once you know the skin manifestations as well as you know the musculoskeletal features, before we actually go into the single organ-wise involvement, let's see through the strict criteria just to see whether we've understood everything. ANA, DSDNA, Smith, anti-vascular antibody, low complements, and direct boosters, which is for autoimmune anemia. ACLE, CCLE, oral rash, non-scarring alopecia, arthritis, cirrhosis, renal, neurological, hematopenia, leukopenia, thrombocytopenia. That's it. This we are again going to see the other manifestations, just to again see whether we are discussing in sequence and in correct format so that everything fits into the tables in the book. Okay, so till this point we have seen. Now the remaining manifestations we are going to see. Remaining manifestations are actually speaking very simple when we try to look at it in a head-to-foot fashion, starting with CNS and ocular, just like we did in RA. So first point I told you in RA was brain activity is not involved. Here I am trying to correct that and say that there is going to be cognitive dysfunction. That is the most common manifestation, and you have an antibody for that. That is called anti-glutamate antibody. For psychosis and depression, we have anti-ribosomal P antibody. So that's the first thing. Second thing is this C1, C2 involvement, atlas axis involvement, erosion of the rheumatoid process, compressive myelopathy. Those things are actually not there, and you can say that the axial skeleton is spared. There, C1, C2 is not rest of spared. Here, the entire axial skeleton is spared. Correct. 3 here again, there is absolutely no chance for any entrapment neuropathy. So entrapment neuropathy is also not there because there is no hypertrophy of the synovial. Synovial hypertrophy, planus formation, etc. Although there is synovitis, it's present there, but it is not so much like in RA to produce entrapment neuropathy. Fourth point is small fiber neuropathy, like what you saw in RA, can be seen here also. So small fiber neuropathy, you can put a tick here also. Right, ocular manifestations. Ocular manifestation that is common to both SLE and RA is the absence of uveitis. And of course, the most common ocular manifestation for RA and SLE is going to be secondary jugular. For RA and SLE is going to be secondary jugular. Correct. But scleritis, etc., whatever we discussed with respect to RA doesn't stand here. Scleritis, etc., whatever we discussed with respect to RA doesn't stand here. Okay, so that is very clear. Then we come to the next one, that is hematological. Hematological is very easy because we have already seen that in RA. The differences are very simple. Anemia of chronic disease as well as warm antibody mediated autoimmune hemolytic anemia of the direct Mbbs test are same with that of RA. But very important differences, you'll see leukopenia here, but leukopenia, lymphopenia is not seen in RA. Thrombocytopenia is seen here because of secondary ITP. Secondary ITP in RA is much rare. These are differences. The risk for DLBCL is there with SLE, it is there with RA also. But large granular lymphocytic leukemia, Fenty syndrome, those things are not seen with SLE. That's very easy. So then we come to the lung manifestations. Lung manifestations, single most important thing is blood vessel disease falls on the kidney. So ILD is not there, ILD is not there. When you think of lung manifestation, most common is same as that of RA, which is pleuritis plus or minus effusion. Correct. There also is pleuritis plus or minus effusion. Both are lymphocytic exudative effusions, but the important difference is RA will have low sugars, SLE will have normal sugars. Second point is that you can have a very aggressive manifestation of filling the alveoli with blood, which is called diffuse alveolar hemorrhage. Diffuse alveolar hemorrhage is also a marker of high disease activity. So high disease activity, you can have diffuse alveolar hemorrhage. Right, then comes serious manifestations. Serious manifestation per se when you look into the cardiac manifestation and then you look into the vascular manifestation. Cardiac manifestations are exactly like RA. Pericarditis without ambulate is the most common cardiac manifestation. You will see MR as the most common valvular heart disease. One more additional finding is Lippmann-Sachs endocarditis, which is not seen so much in RA but seen in SLE, which is vegetation on the under surface of the valve. So that is Lippmann-Sachs endocarditis. Vascular is same. You are having, especially after the first 5 to 10 years, highest risk for ACS is seen after the 5 to 10 years. Similarly, vasculitis here also most commonly is immune complex mediated small vessel vasculitis like RA, classically identified by leukocytoclastic vasculitis or leukocytoclastic angiitis. Now the problem is the dangerous forms. Dangerous forms in RA, I was always talking about gangrene. Now, that is not so much here. Here the dangerous forms are GI and CNS vasculitis. CNS vasculitis is very important. That's not seen in RA. Here you can see CNS vasculitis. Correct? And it's important to know because CNS vasculitis and diffuse alveolar hemorrhage in SLE are two indications for plasmapheresis. Okay, the dangerous form of vasculitis in RA was an indication to start infection. Here, CNS vasculitis and diffuse alveolar hemorrhage are indications to start infection on plasmapheresis. Correct, that's it. Then comes renal. Now, renal is the most important part here because renal as such was not seen in RA. RA I told you will not be having renal. Rarely membranes you can get. Importantly, amyloidosis you can get, but nothing per se with respect to the glomerulus. But renal in lupus is so very important. We have class 1 and class 2 here, which is minimal mesangial and proliferative. So minimal mesangial and proliferative, where nothing you have to be knowing. Treat them. So minimal mesangial means you'll be having immune complex deposits in the mesangium. Mesangial proliferative means immune complex deposits in the mesangium and mesangial proliferation also. But for class 1 and 2, there is no treatment required. Class 5 is called lupus membranous nephropathy. Membranous nephropathy in lupus is class 5, which is actually speaking very refractory to conventional steroid therapy. So it is refractory to steroid therapy. And many times we go with combinations involving MMF and CNI to treat this. Although it is refractory to steroid therapy, the risk for CKD is much less in comparison to 3 and 4. So risk for CKD is much less, but it is actually speaking the most refractory, mostly managed with MMF and CNI based therapies. Okay, what we are interested when we talk about lupus nephritis is mostly this class 3 and 4, which is full of activity. When less than 50% global layer involved, it is called focal, and when more than 50% global layer involved, it is called diffuse. Diffuse is the most common type, it is the most dangerous type also as far as this is concerned. Okay, and here you need very aggressive immunosuppression, extremely aggressive immunosuppression. Diffuse proliferative lupus nephritis is identified mostly on the immunofluorescence, where you see the full house appearance. Full house appearance is what we see under immunofluorescence. Can be seen in HIV also, but very classic. IgG, IgM, IgA, C1q, and C2. So C1q and C3. These many things are actually seen. This is called full house appearance. And on electron microscopy, you have a very specific appearance called, very specific identity called hematoxylin bodies of Cross. Hematoxylin bodies of Cross. So much you have to understand with respect to lupus nephritis. There is no point in going too much into detail. Other important points have been discussed, but this is the basic statement. He who treats SLE without renal biopsy sails an uncharted sea, but he who treats SLE without renal insight is not going to the sea at all. So that is what I also feel with respect to medicine. He who actually tries to study medicine without getting into the crux of the matter is sailing an uncharted sea. But somebody who never tries to attempt that is not going to the sea at all. This is again to show you the effusion, the plural effusion that you can see with SLE. But I'm trying to give you a very important message here. Every number of times that when you have a SLE patient coming to you with the plural effusion, what you have to be thinking is that I have to confirm this plural effusion is because of SLE itself. That is my responsibility. Because the plural effusion need not be due to SLE, right? Can be due to a pneumonia, can be due to pneumonia is okay, the other failures will be there, can be due to a malignancy, so we have to be very careful with that. Okay, finally, how you treat SLE. How you treat SLE is based on whether you are having organ or life-threatening manifestations, we are having no organ or life-threatening manifestations, okay, this way, and a simple SLE with only skin and joint involvement. Okay, so when you think of SLE per se with a skin and joint involvement with no organ or life-threatening manifestation, we can use oral steroid, we can use HCQ, and based on whether arthritis is there or not, we can start revision on methotrexate. This is more than enough. And Mbbs is another drug that has been approved. Mbbs is a B lymphocyte stimulation inhibitor. So Mbbs can be tried. Methotrexate can be tried when there is arthritis. Oral steroid and HCQ are mandatory. For organ or life-threatening, especially for venous, DH and CNS hospitals require flex also. We require IV midalpred followed by oral prednisolone. So IV midalpred followed by oral prednisolone with either cyclophosphamide IV, okay, or MMF. So cyclophosphamide IV or MMF, both are equally good. And at the end of 3 months, you again monitor to see whether it is working. If it is not working, you change from cyclophosphamide MMF, or you change from MMF back to cyclophosphamide, or you change. Either way, you can actually change. So 3 months is the time that you actually give this. Cyclophosphamide means 6 injections, 1 every 2 weeks. MMF means oral 2 to 3 grams per day. Okay. Suppose it is working at the end of 3 months, then you go to maintenance. Maintenance means you give low dose oral steroid with MMF or AZA. With MMF, the preferred drug greater than azathioprine, because MMF is a little costly, that's why. And minimum period 3 years you have to give maintenance. At the end of 3 months, if this is not working, then from MMF you change to cyclo, or if it is cyclo you are giving, you give MMF. And at the end of 6 months, nothing is working, means then you are in trouble. That is called resistant lupus. Resistant lupus, many options are there, but what we try is rituximab. That is one option, or a CNI based multi-targeted approach. At your level, you have to remember rituximab is the drug for resistant lupus. That is more than lupus management is much more complex than this, but I think at your level, if you are able to identify these many things, that is more than okay. Okay, and IVIG and all we generally don't give. Plasmapheresis is indicated for diffuse alveolar hemorrhage and CNS vasculitis. So I have tried to compare lupus head to foot with basically the most important RA. Comparing RA with lupus is a very important discussion, and with that we get an idea about the entire spectrum of arthritis. So, welcome to SPA discussion. So we were previously using this terminology called seronegative spondyloarthritis. And all that, so all the way because there are negative people wanted to use the term seronegative spondyloarthritis, but we are not using that anymore. We're using this term called SPA, that means spondyloarthritis. SPA, you have to first of all say as to whether it is an axial predominant SPA or a peripheral predominant SPA. So you have to say whether it is axial predominant SPA or a peripheral predominant SPA. That's the way you put it. Axial predominant SPA can be equal to non-radiographic axial SPA. Okay, non-radiographic axial SPA and radiographic axial SPA. So non-radiographic axial SPA and radiographic axial SPA. Radiographic axial SPA is called ankylosing spondylitis. We'll see. Non-radiographic axial SPA is not called ankylosing spondylitis. So non-radiographic axial SPA, radiographic axial SPA. Under peripheral predominant, you have reactive arthritis. which was previously called as Reiter syndrome. Now we don't call it as Reiter syndrome, we call it reactive arthritis. Psoriatic arthritis, IBD associated arthritis, that is your ulcerative colitis Crohn's disease associated arthritis, what we call as the enteropathic arthritis. So enteropathic arthritis or IBD arthritis, psoriatic arthritis, reactive arthritis. These many adult entities are there. One more entity is juvenile onset SPA. So that is the pediatric entity under this. So juvenile onset spondyloarthritis, peripheral predominant reactive arthritis, psoriatic arthritis, IBD arthritis, axial predominant non-radiographic axial SPA, radiographic axial SPA. These many entities are there under this list. Okay, what is the common binding point of all of them, if you ask me, is HLA-B27. They are all HLA-B27 positive in varying numbers. That's one thing. All of them are RF negative. All of them have RF negative. All of them have some axial component. Although peripheral predominant SPAs are there, even they will be having some axial component. So axial component will be there, and that axial component is sacroiliitis. So all of them will be having some degree of an axial component, and that axial component will be sacroiliitis. Their most common extraarticular manifestation in all these diseases is what we call a 4A uveitis. That's why that's very important to know. We were studying that there is no uveitis in SLA and RA. Most common extraarticular manifestation in all these conditions is a 4A uveitis. 4A uveitis means asymmetrical alternating acute anterior uveitis. So acute anterior asymmetrical uveitis, that is called 4A uveitis. So 4A uveitis is there, sacroiliitis, axial, RF negative, HLA-B27 positive. These are the common features. Okay, and in most of them, TNF alpha will be the central pathogenic cytokine. That's not a general rule, but in many of them, TNF alpha will be the central pathogenic cytokine. And majority of the times, they are seen inside 40 years. Not again as a rule, actually, there are other conditions also. Majority of the time, they are seen under 40 years, and most of the time, they are more common in males than females, and most of them, they are common in males than females. So these are the other common points that we can actually look into. Having understood the common points, let us try to look into the first entity, which is a non-radiographic axial SPA. Okay, so this terminology may be a little confusing for you, and I'm writing the more common familiar terminology, which is radiographic axial SPA. Radiographic axial SPA is called as ankylosing spondylitis, and then we have non-radiographic axial SPA. Why this is important to know is because of all the people with non-radiographic axial SPA, only 5 to 10% of them have ankylosing spondylitis. So that's why we have a big heading called non-radiographic axial SPA, out of which when followed up over a period of 5 to 10 years, only 5 to 10% of people actually develop ankylosing spondylitis. So ankylosing spondylitis is dangerous, but non-radiographic axial SPA is not that dangerous. Let us see what it is. We're talking about a young male here. Okay, although the male-female ratio is 3:1, mostly we're talking of a young male who is in his late teens or early 20s. So late teens or early 20s. Typically, the Mbbs student is the person who is our caricature representation. He will be coming and asking immediately when he has pathway as to whether it is ankylosing spondylitis. Let us see. So here, what are you or how are you trying to describe this? So when you're trying to describe this, there are 3 boxes that you have to actually hit, and then a bit of extraarticular manifestations also. That's how you look at it. Of course, the hallmark is going to be sacroiliitis. So the hallmark is going to be sacroiliitis. It is going to be a bilaterally symmetrical sacroiliitis. So we'll see the symptoms and all that. Bilaterally symmetrical sacroiliitis, and it is going to ascend up forward. So ascend upwards. So bilaterally symmetrical sacroiliitis, that is basically going to ascend up, and of course have a spinal fracture as it keeps on ascending. The most common complication that it can develop is a spinal fracture. So bilaterally symmetrical sacroiliitis ascending upward with a complication of that is spinal fracture. Along with that, definitely they will be having enthesitis. This is very important. Enthesitis is the term that we use with SPA. Okay, what's the meaning of enthesitis? Enthesis is the site where. So the common points, let us try to look into the first entity, which is a non-radiographic axial SPA. Okay, so this terminology may be a little confusing for you, and I'm writing the more common familiar terminology, which is radiographic axial SPA. Radiographic axial SPA is called as ankylosing spondylitis, and then we have non-radiographic axial SPA. Why this is important to know is because of all the people with non-radiographic axial SPA, only 5 to 10% of them have ankylosing spondylitis. So that's why we have a big heading called non-radiographic axial SPA, out of which when followed up over a period of 5 to 10 years, only 5 to 10% of people actually develop ankylosing spondylitis. So ankylosing spondylitis is dangerous, but non-radiographic axial SPA is not that dangerous. Let us see what it is. We're talking about a young male here. Okay, although the male-female ratio is 3:1, mostly we're talking of a young male who is in his late teens or early 20s. So late teens or early 20s. Typically, the Mbbs student is the person who is our caricature representation. He will be coming and asking immediately when he has pathway as to whether it is ankylosing spondylitis. Let us see. So here, what are you or how are you trying to describe this? So when you're trying to describe this, there are 3 boxes that you have to actually hit, and then a bit of extraarticular manifestations also. That's how you look at it. Of course, the hallmark is going to be sacroiliitis. So the hallmark is going to be sacroiliitis. It is going to be a bilaterally symmetrical sacroiliitis. We'll see the symptoms and all that. Bilaterally symmetrical sacroiliitis, and it is going to ascend up forward. So ascend upwards. So bilaterally symmetrical sacroiliitis, that is basically going to ascend up, and of course have a spinal fracture as it keeps on ascending. The most common complication that it can develop is a spinal fracture. So bilaterally symmetrical sacroiliitis ascending upward with a complication possible, that is spinal fracture. Along with that, definitely they'll be having enthesitis. This is very, very, very important. Enthesitis is a term that we use with SPA. Okay, what is the meaning of enthesitis? Enthesis is the site where ligament, tendon, capsule, fascia, etc. attaches to the bone. So there is inflammation that is called as enthesitis. Enthesitis classically you look for heel pain, that is Achilles tendinitis and plantar fasciitis. So Achilles tendinitis and plantar fasciitis are the two classical sites. Alongside with that, there will be root joint involvement. What are the root joints that you know? Hip and shoulder. So don't call it as peripheral. They are called the root joints. So hip and shoulder arthritis. Correct. Along with that, the extra-articular manifestations. Extra-articular manifestation more common is foray uveitis. Then you can have lung involvement, you can have cardiac involvement, you can have renal involvement. This is how you combine. The total, this is how you combine. Lung, most common is bilateral upper lobe fibrosis of the lung. Very, very important. Only two conditions in rheumatology could be upper lobe fibrosis. Everything else is lower lobe. Cardiac is AR for a change in SLE. RA to MR, here it is AR. And renal is secondary IgA nephropathy. In all the spondyloarthritis, the renal manifestation is secondary IgA nephropathy. So all this is important. So this is how we look at the disease. Synovitis plus enthesitis plus root joint involvement plus extra-articular manifestation. Okay, now when I'm writing like this, then you will get a little confused because I told you about non-radiographic and radiographic axial SPA. Non-radiographic axial SPA and radiographic axial SPA, what is the difference? Radiographic axial SPA, we get all these things. Non-radiographic axial SPA, what are we going to get and what is the difference? Let's see. In a non-radiographic axial SPA, the patient will have symptoms. Okay, and MRI will show sacroiliitis. So patient will have symptoms. MRI will show sacroiliitis. HLA-B27 is positive. So HLA-B27 is positive. MRI will show sacroiliitis, and the patient will have symptoms, which means everybody will think that he is having ankylosing spondylitis, and he will be branded as ankylosing spondylitis, and he will be told about the umpteen other complications he can develop because of ankylosing spondylitis, and you will be so afraid. But when you follow them over a period of 5 to 10 years, you understand that only 5 to 10% develop X-ray evidence of sacroiliitis. So only 5 to 10% develop X-ray features of sacroiliitis, and X-ray features of sacroiliitis accompanied by erosions, accompanied by bone fusion, and this bone fusion is what we call as ankylosis, and this ankylosis leads on to what we call as a bamboo. 10% develop X-ray features of sacroiliitis, and X-ray features of sacroiliitis accompanied by erosions, accompanied by bone fusion, and this bone fusion is what we call as ankylosis, and this ankylosis leads on to what we call as a bamboo spine. So when you follow these patients over a period of 5 to 10 years, only 5 to 10% of patients develop this bamboo spine as complication, and then they will develop what? Extra-articular features. Then they will develop what? Root joint involvement, and they will be also having what? Enthesitis. So that is all present only in this AS category. Majority patients whom we are seeing are having non-radiographic axial SPA. Unfortunately, only 5 to 10% out of that are actually going on and developing a proper ankylosing spondylitis. So what is the difference between non-radiographic axial SPA and radiographic axial SPA? Radiography here means X-ray. X-ray is the important investigation. X-ray, when you are seeing sacroiliitis, that is when you say that you are having ankylosing spondylitis. Okay, so now let us see how is the patient going to come to you. So here the word chronic means 3 months. In RA to 6 weeks, here it is 3 months. He is going to complain to you back pain. Okay, that is where you have to be very, very careful. This is not back pain. It is inflammatory back pain. And I will try to correct it as inflammatory alternating buttock pain. So inflammatory alternating buttock pain. So what is the meaning of inflammatory alternating buttock pain? Sacroiliitis means you cannot have thoracic lumbar pain and all. You are going to have buttock pain mostly, or deep low back pain, and that is going to be alternating buttock pain. And why did I use the word inflammatory? Because it is right early morning that the patient is going to have these symptoms. Nocturnal awakening because of these symptoms, and it improves with activity. So early morning symptoms which improves with activity. That is so typical of inflammatory back pain, and it is this inflammatory back pain that you are looking for. So early morning symptoms improving with activity, it is inflammatory back pain. That's why inflammatory early morning stiffness is so important. Here 30 minutes is the time. Peripheral we generally say 45 minutes, here is 30 minutes. So symptoms at the middle of the night or say early morning hours, not we say second half of sleep as per the textbook, and the patient getting awakening in the second half of sleep because of pain, and then going around walking and doing something, and then again coming back and sleeping comfortably, which is lasting for more than 30 minutes, and it is mostly a deep low back pain or a buffet. Okay, that's very, very clear. And with that, enthesitis. Very, very important, enthesitis. But enthesitis all get prominent if it is, ankylosing spondylitis. In the non-radiographic axial spine, these things are not very prominent. Okay, let us look into what happens here. The inflammatory granulation tissue is what we are having. This inflammatory granulation tissue is going to erode your annulus fibrosus. So the annulus fibrosis is the one that is getting affected here. And it is also going to cause calcification of the peripheral fibers of the annulus fibrosis. So calcification of the peripheral fibers of annulus fibrosis. This calcification of the peripheral fibers of annulus fibrosis is what we call as a syndesmophyte. Very, very important. Is what we call as a syndesmophyte. Okay. When you are having a syndesmophyte formation, always remember that the syndesmophytes in ankylosing spondylitis are thin, marginal, symmetrical syndesmophytes. Very, very important question. They are very small. They don't cross the margin. They are actually symmetrical syndesmophytes. These thin, marginal, symmetrical syndesmophytes are actually being formed. Annulus fibrosis is being eroded. Vertebra glide one over the other, and then you are having bony ankylosis. This bony ankylosis leads on to what we call as a proper spine. This is how the disease progresses. Okay, so I think the understanding is very, very clear. What is non-radiographic axial spa, what is radiographic axial spa, and you actually get to put it. So when you want to write down ankylosing spondylitis now, you must first say that it is bilaterally symmetrical sacroiliitis. This is the first word that has to come to your mind. Okay, where the biggest complication that we expect is spinal fracture, and you must know that there are syndesmophytes, and the syndesmophytes are called TMS, thin marginal symmetrical syndesmophyte. Okay, along with that, you must know that there is enthesitis. Along with that, you must know that there is root and shoulder involvement, and along with that you must know there is extra-articular. And in extra-articular, for all these diseases, the most common extra-articular manifestation is uveitis. Okay, so I think this understanding is very, very clear. Right? Now, always keep in mind that ligamentous calcification, ligamentous calcification can lead on to a flowing candidiac appearance. This ligamentous calcification, which is associated with the flowing candidiac appearance, is called diffuse idiopathic skeletal hyperostosis, or DISH. DISH is nowhere related to ankylosing spondylitis. I don't know why we are comparing in the first place. This is part of a metabolic syndrome. It's more related to obesity and all those things. Intervertebral disc space is preserved in this. Okay, and also that there is no sacroiliitis in DISH. So I don't know what way it is comparable, but this for the exam, please keep in mind. Okay, so that is about ankylosing spondylitis. Last part is that the fractures are mostly in C5, C6. Don't ask me why. Fractures are not in thoracic or lumbar. Fractures are more common in C5, C6. Right, we don't know the exact reasons, but maybe ascending, it may actually be like that. Okay, how do you treat ankylosing spondylitis? Ankylosing spondylitis is one disease where NSAIDs have major role to play. They can reverse the natural progression of the disease in only two settings, ankylosing spondylitis and reactive arthritis. So physiotherapy and NSAIDs is definitely our first line. We are not going to waste time. We are going to go to physiotherapy and NSAIDs. Very, very importantly, any short course of NSAIDs, okay, for 2 to 3 weeks, either indomethacin 15 mg TDS or brufen 80 or 800 mg TDS or naproxen 550 mg BD. Any of this you can use. Indomethacin is slightly superior. If this is not working, then of course TNF alpha inhibitors, no doubt about it. TNF alpha inhibitors, and now interleukin 17 antagonists, because interleukin 17 23 pathway is also found to be a very important pathway in ankylosing spondylitis. That's a major update. So because of that, interleukin 17 antagonist called secukinumab in so many studies and now has been shown for me useful. So interleukin 17 is also now very much part of this. That is how we manage this. Okay, so non-radiographic spa, radiographic spa, and radiographic spa is what we call ankylosing spondylitis. So that's it. We're just again going through this point to understand that only very few patients will go on and develop this. So symptoms before 45 years, correct. 3 months, correct. Low back or alternating buttock pain. Second half of night, 30 minutes. Insidious onset, improvement with exercise. No improvement with rest, and improvement with NSAIDs. All the features. If you know the disease properly, when you read, everything will put in place. Enthesitis is the key factor, correct. Newborn formation at the site of enthesis is called syndesmophyte. That's not correct. Calcification of the annulus fibrosis is called as a syndesmophyte. It is a vertical osteophyte or a syndesmophyte. Okay. Newborn formation, you don't actually entertain that name. Inflammation, bone erosion, correct. Differentiating from RA, all the points we can actually see. Inflammatory back pain, correct. Enthesitis at the costocaudal junction can produce chest pain. That I forgot to tell you. Extra-articular tenderness due to enthesitis, heel pain, plantar fasciitis, all that. Root joints are getting involved, hip and shoulder. Acute alternating anterior asymmetrical uveitis, that is called the 4 uveitis. Aortic regurgitation, lung bilateral upper lobe fibrosis, C5, C6 fracture, renal secondary IgA nephropathy, and osteoporosis is seen in 2 conditions in rheumatology. One is RA, second is AS. And then apart from this, what else are the X-ray findings that you're expected to know? One is your vertebrae will become like square wave vertebrae. Erosions with secondary sclerosis is there. Erosion is called as your Romano sign, and secondary sclerosis is called as your shiny corner sign. So shiny corner sign and Romano sign. Then you have the dagger sign, which is your interspinous ligament calcification. Then your trolley track sign, that is your apophyseal joint capsule calcification. So trolley track sign, dagger sign. So square wave, Romano sign, dagger sign, trolley track sign. But the best investigation is still the X-ray. That's what I'm saying. Without X-ray, you cannot say that there is ankylosing spondylitis. Although we use MRI to look for sacroiliitis, even non-radiographic axial SPA can have MRI findings. An MRI sequence that we look for is called the STIR sequence. It's a specialized T2 sequence, short tau inversion recovery sequence. It is a STIR sequence MRI that is required for diagnosis. Then this modified Schauber test, which I think all of you would have done in your wards. They just asked the name. They haven't asked you how to do the test, but I think everybody will be knowing, right? 2 dimples, 5 cm below, 10 cm above. So total 15 cm. From there, more than 5 cm, there should be an increase. Okay, if you haven't done that, that's bad. Right? So that's about exercise treatment, everything we have answered. See, no role for any steroid at all. Okay, intraarticular steroids may be given for pain relief, but apart from that, nothing much. That is ankylosing spondylitis. From ankylosing spondylitis, we move to what is called reactive arthritis. Okay, reactive arthritis. Reactive arthritis is a very, very important short topic because you're often asked to compare. Let me just try to get every point straight on reactive arthritis. Previously called Raynaud's syndrome, urethritis arthritis meningitis. That has no meaning. Let us try to understand that this is an example of infective plus HLA. Right? So this is post-infective, and then you are having an HLA also. HLA is HLA-B27. I did not mention HLA-B27 so much in ankylosing spondylitis because that is not no meaning per se. 90-95% people are positive. That's it. But here HLA-B27 positivity is equal to a risk for chronic reactive arthritis. So chronic reactive arthritis is seen in 15 to 20%, and that is actually speaking associated with B27. So B27 has got something problematic here. Yes, this is generally post-infective. Post-infective means after a period of 2 to 4 weeks after the infection. That is when you get reactive arthritis. The infection can be a GUT infection or a GIT infection. Can be a GUT infection or a GIT infection. Most common cause worldwide is chlamydia trachomatis. So genitourinary tract infection, chlamydia trachomatis is the most common cause worldwide. GIT infection caused by Shigella vaccinari is a very important cause in India. In fact, the most common cause in India is Shigella infection caused by, Shigella vaccinari. Then you have upper respiratory tract infection, that is beta hemolytic streptococci, okay, and chlamydia pneumoniae. So chlamydia pneumoniae and beta hemolytic streptococci, upper respiratory tract infection. These are the three things of which worldwide it's chlamydia trachomatis, India it is Shigella vaccinari. Okay, if you get a question for the exam, always chlamydia trachomatis because all the data extensively across the world is from that. And this GUT associated reactive arthritis has a 9:1 male female ratio. Very, very important. GAT associated one has a 1:1 male female ratio. So GAT is 1:1, GUT is 9:1. Okay, so I think that is also very, very clear. And what kind of an arthritis are you actually getting? You are getting an acute onset sterile non-purulent arthritis. Okay, organism may be present inside the monocytes of the synovium that we are not including anywhere, but we call it as an acute onset non-purulent sterile arthritis. Organism may be present inside the monocytes of the synovium, but still I'm telling it is for the exam acute onset sterile non-purulent arthritis is what I'm calling it as. Okay, so things are clear. So I think now it is understood. 2 MCQs I want you to remember is chlamydia is there, but Neisseria is not there. So Neisseria, if you get an option, mark it wrong. All the organisms are there in GAT, but E. coli is not there. So this much I want you to remember. So E. coli is not there, Neisseria is not there. Fine. So that's right. Let us try to place the disease. So I'm telling you it is a peripheral predominant SPA. That's what I told you, peripheral predominant SPA with the axial component in around 1/3 of patients, so 30%. Axial component in 1/3 of patients with the enthesitis, with the dactylitis. So very, very important, with the mucocutaneous changes. So enthesitis, dactylitis, mucocutaneous changes with axial plus peripheral. It's a peripheral predominant SPA. This is how you place the disease. And enthesitis and dactylitis are most prominent in reactive arthritis and psoriatic arthritis. Those are the two conditions where both are extraordinarily prominent. Okay, so how you place it? Peripheral predominant SPA. How will you write? This is going to be a asymmetric involvement. Lower limb more than upper limb involvement. And it is going to be an arthritis per se involving the synovium. So synovitis, asymmetrical, lower limb more than upper limb. So asymmetrical, lower limb more than upper limb. And this is going to be oligoarthritis. So that's why asymmetrical lower limb oligoarthritis always, I told you, psoriatic arthritis, and this one has to come to mind. And the most important 3 terms with respect to this arthritis are ARP arthritis. A stands for asymmetrical arthritis, A stands for addictive arthritis, P stands for painful arthritis. All the 3 words are very, very important. Additive means knee, the knee plus angle, the knee plus angle plus subtalar, the knee plus angle plus subtalar plus metatarsal angle. It keeps on adding. That way. Painful means it is a very, very painful arthritis. Like gout. Gout is called the king of arthritis because it is most painful. So ARP arthritis, that's how it is. Okay, so whenever you think of asymmetrical lower limb arthritis, I told you a pattern itself. Like when it is mono, it's a different discussion. Oligoarthritis is psoriatic and reactive. Routine arthritis is asymmetrical sacroiliitis. In ankylosing spondylitis, what did I tell you? Symmetrical sacroiliitis. And here the syndesmophytes are thick syndesmophytes, non-marginal syndesmophytes, coarse fluffy syndesmophytes. So they are thin, marginal, symmetrical syndesmophyte. Here thick, non-marginal non-marginal, coarse, fluffy, asymmetrical syndesmophyte. Because the syndesmophyte there was due to annulus fibrosus calcification. Here it is mostly due to paravertebral ossification. You don't have to know that it is mostly due to paravertebral ossification, but it's completely different. Okay, thin marginal symmetrical syndesmophyte was seen with ankylosing spondylitis. Thick non-marginal asymmetrical coarse fluffy syndesmophyte is seen with reactive arthritis as well as with psoriatic arthritis. Both places you can see this. Okay, enthesitis is the same. So very prominent enthesitis, heel pain as well as plantar fasciitis, Achilles tendinitis. Dactylitis is a very, very important manifestation here. Whenever you hear the word dactylitis, reactive arthritis and psoriatic arthritis have to come to mind. It's called sausage digit. Yes, and mucocutaneous changes. Mucocutaneous changes can be oral ulcer and two very, very important skin lesions. So let's see those two skin lesions asked so many times for the exam. Then we'll come back to this. The two very important skin lesions. One is called keratoderma bleneragica. This is hyperkeratotic vesicles on the palms and soles which crust. This is after crusting that you're seeing this keratoderma bleneragica. And the second one is circinate berenitis. This is circinate berenitis, which is a painless, shallow erythematous ulcer of the gland spinous. So painless, shallow erythematous ulcer of the gland spinous, which is called circinate berenitis. So never forget keratoderma bleneragica and never forget circinate berenitis. Along with that, never forget dactylitis, sausage digit. Never forget this is arthritis of the knee joint, dactylitis, enthesitis, all these things. Okay, so I think I made the discussion as easy as I probably can. Correct? So we have understood everything. So what are the things that have to come to your mind when you think of the disease called AS means, what did I tell you? AS is equal to inflammatory back pain. Okay, inflammatory back pain plus enthesitis plus root joints plus extraarticular. So this is how you study ankylosing spondylitis. In this inflammatory back pain, I will put it as bilateral sacroiliitis. So this is the way you put it. With what syndesmophyte? Thin marginal symmetrical syndesmophyte. When you write reactive arthritis, then it has to be peripheral predominant, correct? Where we are using the word called asymmetrical oligoarthritis, which is large joint predominant, knee starting, and it is additive and painful. Additive and painful. Then along with that, we are having axial involvement in 1/3, where we are having the opposite of TMS. Instead of thin, thick, marginal, non-marginal, symmetrical, asymmetrical, coarse, fluffy, large syndesmophyte. Then very prominent we are having enthesitis, very prominent we are having dactylitis. Plus we are having mucocutaneous changes. The mucocutaneous changes for the exam that you have to keep in mind are keratoderma bleneragica and circinate berenitis. Okay, how do you treat it again? NSAIDs have been found to work so beautifully in this. Indomethacin is often considered as a drug which can work wonders in ankylosing spondylitis and reactive arthritis. 50 mg TDS is the dose. Chronicity is seen in 15 to 20%, and in that population who are chronic, sulfasalazine has been tried. That's all. DMARD is useful for chronic persistent reactive arthritis, and that too, only sulfasalazine. Last point is, can you have extraarticular manifestations here? Yes, AR can be seen. Lung involvement, renal involvement are actually speaking very, 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 very uncommon. AR can be seen, conduction blocks may be seen because of that. But lung is almost absent, renal is very, very, very rare. This is equal to, and this is equal to reactive arthritis. From reactive arthritis, before going into psoriatic arthritis, that is where actually we should be going into next. We will go into a very, very important short topic, which is also very important for the exam. That is IBD arthritis. Okay, that is IBD arthritis. IBD arthritis, every single point is important for the exam. It is more commonly seen in Crohn's disease than ulcerative colitis, number one. Male-female ratio here is 1:1. So male-female ratio is more in favor of males in the first two. This is male-female ratio 1:1. HLA-B27 positive people can have a axial arthropathy here. Axial arthropathy, which is very similar to ankylosing spondylitis. So they can have an axial arthropathy very similar to ankylosing spondylitis, but the risk is only 10%. So only 10% of the people have this kind of arthritis. 25% of the population actually are having peripheral arthritis. So 25% of the population are having peripheral arthritis. Only 10% are having ankylosing spondylitis like arthritis. Then we also have to know that anti-TNF alpha is the drug of choice here. So anti-TNF alpha is actually speaking the drug of choice here. So we have to be comparing between the two forms of peripheral arthritis. The two forms of peripheral arthritis are extremely, extremely important for the exam. Let us study the two forms of peripheral arthritis, type 1 arthritis and type 2 arthritis. So type 1 arthritis, type 2 arthritis. Type 1 arthritis is called as LMAP. Okay, type 2 arthritis is called SMAP-U. So type 1 arthritis is called LMAP, type 2 arthritis is called SMAP-U. That is a goal. What is the meaning of LMAP? LMAP means large joint. So that's the first point. That is knee predominant. So large joint, knee predominant. M stands for migratory. Okay, migratory. A stands for asymmetric. So large joint, migratory, asymmetric, posi-articular. Okay, posi-articular arthritis. So large joint, knee predominant, migratory, asymmetrical, posi-articular arthritis, which correlates with disease activity. That means correlates with bowel activity. When you are having a relapse of IBD, the three findings that actually correlate with the relapse in IBD are episcleritis, erythema nodosum, and LMAP. So these three things have to go hand in hand. That is the point about LMAP. And LMAP is generally very much self-limiting. LMAP is self-limiting. Okay, when we come to SMAP-U, SMAP-U is type 2 arthritis, which is small joint predominant. So the most common joint involved is the MCP joint. It's a small joint predominant, migratory, there you have to be careful. It is not asymmetric, it is aggressive. So small joint predominant, migratory, aggressive. So it's not self-limiting, it is aggressive. And it is not POSI, it is polyarticular arthritis. So small joint predominant, migratory, aggressive, polyarticular arthritis with uveitis. Okay, so small joint, migratory, aggressive, polyarticular arthritis with uveitis is type 2, and it does not correlate with bowel activity. So no correlation with bowel activity. Episcleritis correlates, but scleritis doesn't correlate. Erythema correlates, but pyoderma gangrenosum doesn't correlate. LMAP correlates, but SNAP doesn't correlate. Very, very important. So no correlation with bowel activity. These are the two types. And thus we go to the last topic, psoriatic arthritis. I don't know, every rheumatologist in this world seems to be so fond of psoriatic arthritis. Ever since I stepped into the department of rheumatology at NMC, I've been thinking this. Every topic we start discussing, we go to psoriatic arthritis. Psoriatic arthritis is the favorite topic of, I think, hundreds of rheumatologists. In fact, that's how it is. So we'll see what is so special about psoriatic arthritis. For the entrance exam, 7 to 40% of people with psoriasis can develop arthritis. That is the first point you should be knowing. Psoriatic arthritis is actually speaking equally seen in males and females, and the only spondyloarthritis that is seen above 40 years. All the others that we have discussed that are young people. HLA, CWC, on the entrance exam, 7 to 40% of people with psoriasis can develop arthritis. That is the first point you should be knowing. Psoriatic arthritis is actually speaking equally seen in males and females, and the only spondyloarthritis that is seen above 40 years. All the others that we have discussed that are young people. HLA CW60602 is the most important HLA here, not HLA B27. B27 is there, but CW60602 is the most important HLA here, and it is a peripheral predominant, which you've seen. Just like reactive arthritis, this is also going to be a peripheral predominant arthritis. It is the plaque type psoriasis where you are going to get maximum number of changes with respect to the joint. And remember that pustular psoriasis can produce extensive destruction, but pustular psoriasis is associated with HIV patients. So pustular psoriasis can produce extensive joint destruction, and that is associated with HIV patients. But more commonly, where we see arthritis means we see arthritis in the plaque type psoriasis category. Okay, when we start discussing psoriatic arthritis, I think the 60-20-20 rule is a very important rule that we have to discuss. 60% patients can have psoriasis first followed by arthritis. 20% patients can have psoriasis and arthritis together. But we are really worried about this 20% who have arthritis first and they have psoriasis. That is why this 20% is a very, very important topic. And also be knowing that psoriatic arthritis is associated with a whole lot of nail changes. And nail changes are seen in more than 90 to 95% of the patients, including pitting, which is the most common nail change. Onycholysis, the separation of the nail plate from the nail bed. You can have yellowish nail margin. You can have horizontal ridging also. So horizontal ridging, yellowish nail margin, onycholysis, pitting, all these things can be seen. Correct? When it comes to the patterns of arthritis and psoriasis, 4 patterns are extremely important. Fifth one is destruction, which is arthritis mutilans. 4 patterns are very, very important for the exam. Most common is the symmetrical polyarthritis. So I told you, whenever you are having symmetrical polyarthritis, you have so many diseases to be brought to mind. But when PNP, DIP, MCP, everything is getting involved, then naturally it is psoriatic arthritis. We can have reactive arthritis like pattern, what we call